أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. My, my dear house officers, my students and those who are in third year and fourth year MBBS and those who are practicing physicians or those who are dealing in the wards. Now these type of the problems which I say that there is a very simple question was asked by my student that nobody is guiding the house officer on the correct path when they are dealing with the patient. And he or she said that there are a lot of patients of the what is so-called chronic liver disease. Terminology she used chronic liver disease. I already said that there are specific diseases which should be mentioned. Simple question is mine is that whether this patient is now in a cirrhotic state. He develops cirrhosis, because I already described what is cirrhosis. And the result of the cirrhosis, mean complication of the cirrhosis has been discussed previously in my last lecture. That is the development of the portal hypertension. Now today I am Dr. S. Hazar and I am talking on behalf of visiting professor of medicine at JSMU, so-called. What is the general clinical management of cirrhosis? What are the causes of cirrhosis? How it develops? It was already discussed previously many times. Now, cirrhosis, if it is diagnosed as cirrhosis, then first of all, see what is the etiology behind it. For example, it is hepatitis B. Manage the hepatitis B. Whether the patient has developed cirrhosis. What is the advantage now? Our patient has already developed cirrhosis. Why you are dealing with the antiviral drugs? Why? Because has been previously discussed and previously proved that in the papers that if you give the antiviral drugs, although the patient develops cirrhosis, it will be benefited that the cirrhosis, there are about 60 to 70% reduction of chances of developing the hepatocellular carcinoma. Then prophylactic treatment. The complication associated with the cirrhosis leading to the different type of problems, the portal hypertension and so on and so forth. The prophylactic treatment should be given. As for portal hypertension, I am focusing on a prophylactic treatment or treatment of the portal hypertension. But anyway, we will discuss later on. The third is the pre-transplantation care, because you are planning the transplantation or what is called substitute of the transplantation. Care the patient procedure management, that is called. Consent should be taken, and the other cost effectiveness is the problem with these patients. So managed accordingly. And the liver transplantation. Now this is a big thing. It has been already come in the media that liver transplantation is going on in the different parts of the country. We are in a position to do the liver transplantation. Remember that the people who are involving in this transplantation, they are not confident. They are not confident, they are terrified that the transplantation will be failed. So they will select very few patients for the liver transplantation. वो कहते हैं ना, तो पख जो लगाई है उन्होंने इसमें, वो यही लगाई है इम्पोर्टेंट, जो पख है वो ये लगाई है कि आपकी एज जो है वो अगर 50 साल से ज़्यादा हो गई है फिर तो हम नहीं करेंगे, पहली पख। दूसरी जो उन्होंने प्रॉब्लम क्रिएट की है वो क्या की है कि आपके पास जो है ना वो डोनर जो होना चाहिए, डोनर होना चाहिए। कौन सा डोनर? यानी वो जो ब्लड रिलेशन रखता हो और वो मैच कर जाए, उसका HLA 100% मैच करे, तो वो होना चाहिए। तो वो जो है जब तक नहीं मैच करेगा, जब तक आप नहीं कर सकते। ये जो चीज़ है ये पख कहलाती है, ऑब्जेक्शंस कहलाते हैं, वो करना ही नहीं चाहते। यही हाल जो है ना थोरेसिक सर्जरी का है कि वो पढ़ लेते हैं FCPS थोरेसिक सर्जरी में कर रहे होते हैं, फिजिशियन के दर पे काम, बहुत कम जो है वो इंटरवेंशन करते हैं, वो डरते हैं, खौफजदा होते हैं। इसके लिए जो है ना बहुत दिल गुर्दा चाहिए होता है, तो वो नहीं है मौजूद। ब्रेवरी जो होती है ना, जो पैदा होती है, काम करने वालों को कॉन्फिडेंस होना चाहिए, ब्रेवरी डेवलप करनी चाहिए, वो है नहीं। है नहीं भाई, छोड़ें इस किस्से को। तो अब आप आइए कि इसका जो शाखसाना है जो पोर्टल हाइपरटेंशन का, एंड दैट इज द वेराइसिस एंड द वेराइसल hemorrhage. Why it occurs? Because of the high pressure in the portal vein. Backflow, back pressure develop, splenic vasodilation occur, mean that portal vein will be dilated, the splenic vein will be dilated, the superior mesenteric will be dilated, the inferior mesenteric vein will be dilated. Important thing where the anastomosis between the portal and the cable systems. And one is at the junction of the gastroesophageal junction. And by this, because the pressure is mounting here at this gastroesophageal junction, where there is portal cable anastomosis, there will be the growth of the anastomosis, which is called variceal growth. Now, the cirrhosis will cause resistance to the portal flow. It will cause a high portal pressure, reflected as splenic arterial resistance, reduction of it, and increase in the portal blood inflow. And this leads to the imbalances, will lead to the varices. This is the varices. So varices occurs due to this. Now varices day by day increase in diameter progressively. Here it is just this, the erythema, and then small varices develop here. Look, this bluish tinge, and then will be the large type of, sigmoidal type of activity here seen in these varices. They are about to rupture. They are not ruptured yet. Day by day, increasing in the size of this. Here it is very smooth. Here this is localized. Here it is sigmoidal type of a dilatation. Then the cirrhosis, I said already that this varices will lead to the variceal rupture. This is the problem. You face it. This is the varices is ruptured now, and the bleeding comes out, irritating the esophagus, and you go for the hematemesis. Another point is this is seeing the varix with the red signs. It is the sign with varices, it will rupture at any time. These are called the predictors of hemorrhage. Size of the varices, red signs which I have shown here, and the child criteria. We know about the child PERC criteria, and this is the criteria of the total bilirubin, visceral albumin, and PTNR and SIT, the petechical encephalopathy, if the total bilirubin is less than 34, 1 point, serum albumin less than 35, 1 point, PTINR less than 1.7, 1 point, ascites none, 1 point, and the hepatic encephalopathy none, 1 point. Now here the other 2 points means total bilirubin is more than 34 to 50 micromole per liter, means 3.4 to 5. Serum albumin in 28 to 35, 2.8 to 3.5, between it means that. Again 2 points, and PTINR is how much increased to 1.71 to 2.3. And then the ascites here is mild, only few places showing the ascites, difficult to detect by the clinical examination although. Hepatic encephalopathy grade 1 or 2 means that the patient sleep is disturbed or patient is in stress, unusual stress. This is the points of the two points each. If the total bilirubin is increased to more than 5 and serum albumin is less than 2.8, the pH in NIR is more than 2.30, or ascites is moderate to severe, it means that you can go for the fluid cell or shifting dullness, and clinically an hepatic encephalopathy is of more than grade 3. The patient is very drowsy, stuporous. So they have divided on the basis of these points in class A and B and C. Class A, if it is the total point is 5 to 6, class B is 7 to 9, class C is 10 to 15. And survival rate in the class A is 100%, not bad. Class B is 80%, not bad. Class C 45%, not very bad. This is called child per scoring system. If it is in the child score per system B and C, this is the predictor of hemorrhage. There is no frank hemorrhage now, but it can lead to bleeding at any time. Now to look at this very important diagram. This is the physics which is applied. This is the esophagus, this is the varix, and there are a lot of veins, engorgement, and they are from the both sides, systemic and as well as from the portal. The radius is this varix, this is called R, and transmural pressure, meaning the difference between the pressure outside the varix, inside the means the lumen of the esophagus, and here it is the pressure inside. This is called transmural pressure, TP. And wall thickness will be measured with W. So you will get it, the variceal wall tension, T, that is equal to TP, the transmural pressure multiplied by radius. You calculated it by in the endoscopy, and W is the wall thickness. So it is directly proportional to the transmural pressure, and the radius are inversely proportional to the wall thickness. Less is the wall thickness, more are the chances of the wall tension. More is the wall thickness, less is the chances of the variceal wall tension. If it is the leading determinant rather of the variceal rupture. You can predict. Prediction is important. The decreasing portal pressure reduces the risk of the variceal rupture. Means that there should be a prophylactic measures should be done. To reduce portal pressure, reduce transmural pressure, varix radius, wall thickness should be increased, and variceal wall tension should be decreased, and leading to the less risk of the rupture. How will do? How will you achieve? Meaning prophylactic management. It is a prophylactic management before bleeding occurs. Reduce this pressure by many means. It may be beta blocker like indirol, that is called propranolol. You give the dose starting with a 10 milligram 3 times a day and calculate the pulse. If it is pulse becomes 1/3 of the initial one, then it is the correct dose you have given. You can give the calcium channel blockers. It will help also. You can give also the coronary vasodilators. They are allowed to, because they will also reduce the pressure. There are 3 types of drugs: beta blockers, number 2, the calcium channel blockers. Again, the same formula will be applied with 1/3 of the pulse. And you stop it, the dosage, and maintain it. And thirdly, the coronary vasodilators, nitrates will help in the reduction of the pressure. This is one way to reduce it, the pressure and the risk of the rupture. It's a prophylactic treatment. But another thing which we cannot do here in Pakistan is the hepatic venous pressure gradient, which I have said already. The gradient, if the gradient is here, this gradient is about less than 12 millimeter, then the chances of the bleeding or rebleeding is less. If it is more than 20% from the baseline, from this, then the chances of the bleeding is 7 to 13%. But there is no change in this venous gradient. The chances of bleeding is more, because this is the wedge pressure actually. So if it is high, it means more than 30% of the baseline, the chances are less, because this pressure is transmitted to the liver rather than to the portal vein. And in this fashion, again, lower down and lower down, the chances are of the pressure is this. Although the bleeding chances are more, the pressure chances, the portal pressure will be decreased. But with HVPG gradient, with you're determining the gradient, it will predict it like this, which is seen here. But it is not done in Pakistan. So we'll omit this knowledge. Now this is the prophylactic treatment. I've said that the propranolol should be given 10 milligram 3 times or 4 times a dose, and you have to maintain the pulse rate to 1/3 of the baseline, and treatment should be continued indefinitely, or you use the another source, and that is the calcium channel blocker or nitroglycerin. Here prophylaxis of variceal is written here. Endoscopy will be done nextly. If you are in doubt, with no varices, you follow up this endoscopy in 2 to 3 years, and in small varices, follow up will be done in 1 to 2 years. If the medium and large size varices, you have to use all things, the beta blockers and other things as well. And endoscopal variceal band ligation should be done before it will rupture. And this is the one of this flow chart which is showing you. So we deal with the prophylactic management, and then endoscopically, if it varices, you go for the treatment, and in prophylactic treatment, no problem. Small varices, again the salvage endoscopy should be done into 1 to 2 years, and the mediums are, if it is a medium one, you have to go every 6 months, or if it is much more, after 3 months. Acute variceal hemorrhage occurs in general management now. First of all, by hook or by crook, you have to stop the bleeding. If the bleed arrangement is delayed, you will give the intravenous access. 1 and 2 cannula should be passed, and fluid resuscitation should be done with a normal saline, plasma expanders, ringolactate, whatever is available should be used at once. Do not over-transfuse. If the hemoglobin is 8, because it is diluted and it will lead to the high output cardiac failure. You see the what is known as GVP. Try to see it. If it is high on the higher side, please do not go very fast transfusion of these expanders or fluid resuscitation. Antibiotic prophylaxis should be done. Well, basically, it is from the quinolone group. Should be given. For example, you will use the ciprofloxacin 500 mg BT, or you use the rifaximin. It is also antibiotic prophylaxis. Specific therapy will be given now. You call, if this is actually hemorrhage, to the endoscope, and then start this therapy. Because endoscopist will arrive after 1 hour, 2 hours. You will use these drugs which are available here are the darlipressin, which is available, and they have using it. It is a prodrug of the vasopressin, ABP, somatostatin and analogs can be used here, octreotide that is, and the vasopressin can be used directly, and nitroglycerin plus nitroglycerin, because we don't know underlying heart disease is not, because ECG reading is difficult, most of them. So you do the vasopressin, and the telepressin or vasopressin is given, the nitroglycerin prophylactic should be given. Otherwise, somatostatin analog, the octreotide, it is not necessary. It will definitely reduce the pressure. Then the endoscopist will arrive. At one time, before endoscopy, they are doing the balloon therapy, the 2 balloon, 3 balloon therapy, which is not done nowadays. It is not practiced nowadays. The balloon therapy, pressurization of the balloon. No, it is not done like in any modern medicine now. The endoscopy will be done, and when the endoscopy arrives, he can do ligation, he can do sclerotherapy accordingly. If it is failed, for example, after 7 days again bleeding, then again ligate. He will try 3 times, either the ligation or sclerotherapy. Endoscopic therapy should be done, and plan it for the other therapy for permanent solution. If the patient cannot go for the liver transplantation, then the bridge surgery, that is called TIPS, that is transmural portal systemic shunt, transcutaneous intravascular portal shunt. This is a surgical shunt, or other shunts are available also to reduce the pressure on the liver and on the portal system. This is a bad ligation. You've seen here, this is a picture. Sclerotherapy can be done, but it is the band therapy. There are different types of the bands which you use. There are less rebleeding chances, of less mortality chances, and fewer complications, fewer endoscopic management. Sclerotherapy can be done if you don't have this. A very small varices is there. If there is a medium size or a large one, you have to do the band ligation. And TIPS, that is transjugular intrahepatic portosystemic shunt, or transcutaneous intrajugular intrahepatic portosystemic shunt. There are different types of shunt, but this is popular one, which is done in Shaukat Khan Memorial and also done in SIUT here in Karachi. It will directly communicate, but the problem is with this is the liver is bypassed. So the toxic agent will go directly into the systemic circulation, and the chances of hepatic encephalopathy is more and more. The variceal hemorrhage suspected, the initial management should be done. I have told you acute hemorrhage control should be controlled first. If it is yes, then it is the early rebleeding. If it is no, prophylaxis will be given. I have already told you about it. If the early rebleeding chances are more, the second endoscopy should be done and managed accordingly. Acute hemorrhage is not controlled, then balloon tamponade therapy, sense-taking tube or other tubes can be used at one time, but is not available very, very commonly. They use the rescue therapy. They do for the sclerotherapy or the band therapy and then give the rescue tips shunt surgery. But it's a planned surgery. It will take time. So this is how we manage the acute variceal hemorrhage. 1, 2, 3, 4, 5, 6. These are the points. Number 1, control the bleeding. Number 2, by hook or by crook, the PP should be maintained but not quickly. So the high output cardiac failure should not be achieved. Give normal saline, give rangolactate, give the plasma expander like plasmine, etc., etc. Or you go for the blood then. Blood can be given as, the Paxil should be given. If it is no time, then give the whole blood. Paxil are better expanders. And then, afterwards, call the endoscopist. Wait for him. In this time, you will do the injectable therapy for the vasoconstrictor therapy, that is telepressin, octreotide, or vasopressin, etc. But please give the telepressin and vasopressin, the nitroglycerin should be given because you don't know whether there is a hidden ischemic heart disease is there or not. The endoscope will arrive and then he will examine the patient on that side and will decide for the sclerotherapy or the endoscopic ligation and will advise you that if there is rebleeding 2 or 3 times, then he has to go for the rescue therapy, intermediate, that is called bridge therapy for the TIPSS, and plan for the liver transplantation. And that is the management of the portal hypertension. अब इसको एक एक करके अगर आप लिख लें आप इसको, इसमें जनरल मेजर क्या करने हैं, स्पेसिफिक मेजर क्या करने हैं, फिर आप लिखें इसके सिम्टोमेटिक मेजर्स क्या करने हैं इसमें, फिर इसके आगे लिखें आप कि इसके प्रिवेंटिव मेजर्स क्या करने हैं, फिर इसके आगे लिखें आप इसके डाइटरी मेजरमेंट्स क्या करने हैं। तो भूखा तो नहीं मारेंगे ना, तो आप कुछ ना कुछ तो बताएंगे ना उसको, भाई ये खाओ ये ना खाओ, तो ये बताना है। फिर सर्जिकल मेजर्स, लोकल मेजर्स, ये सारे के सारे मेजर लिखें, चाहे अप्लाई होनी होती तो NA लिख दें वहाँ पे। भाई लाइन से आप लिखेंगे तो आपको याद आ जाएगा कि इस तरह मैनेज इसको करते हैं। तो ये अगर इस तरह आप करेंगे तो आपको याद रहेगा, अदरवाइज अभी 10-15 दिन बाद फिर आपसे पूछा जाएगा, फिर भी आप कंफ्यूज हो जाओगे। मैं ये कहता हूँ कि इस तरह से लिखा जाए जैसे मैंने बताया है। आई होप कि ये आपकी बात समझ में अब आ गई होगी कि अगर कोई आदमी हेमाटोमेसिस आया है और अंडरलाइन सोर्सेज है तो उसके अंदर क्या करना चाहिए। वमा अलैना इल्लल बलाग। अस्सलामु अलैकुम वरहमतुल्लाहि वबरकातुहू।